So this is the final culture results that came back. So the blood was indeed positive for Staph aureus and was persistently positive for 8 days. The skin lesion, as we mentioned, was positive for Staph aureus. After being intubated, the tracheal aspirates were positive for Staph aureus for a full week. He went multiple times to the OR for INDs of the right femur, which were positive times 3 for Staph aureus, and the right knee joint grew out Staph aureus as well. So he has disseminated Staph aureus, and as Nidhi points out, you have to start thinking about what's the nexus of infection, why is he persistently vectoring it, where are all these manifestations coming from. So if you look in the literature, at least in children with disseminated staph disease, DVTs played a very pivotal role in the development of these disseminated infections. And indeed, on ultrasounds of his lower extremities, here you see the popliteal artery, and there's essentially no flow within the vein there. So he had a significant thrombus within the right femoral vein and popliteal vein as well, the left popliteal vein in addition. Staph aureus, if you look in the literature, especially staph osteomyelitis, seems to have some predisposition to forming DVTs. For some reason, whether it's toxin-mediated, it seems to be thrombogenic. And in fact, to kind of complete the circle, when you have staph osteo and a DVT, you're at very, very high risk of disseminated disease. So he did indeed get a bone scan, which showed increased uptake of the left ankle here and diminished activity in the right femur, consistent with infarctions. And as you point out, it's very severe staph osteo. You can actually see decreased uptake on a bone scan. Later, he did get an MRI of the left ankle, which did show osteomyelitis to the fibular metaphysis and a small subperiosteal abscess, which had to be IND'd. And subsequent to this, although they didn't light up on the bone scan, there were multiple other bones which were involved. On MRI of the abdomen, you can see these splenic infarcts here, consistent with embolic disease. The liver is enlarged. The biliary tree seems to be enlarged and inflamed as well. The kidneys are generous and they have poor differentiation of the corticomedullary junction. And although it's not shown on this particular cut, the T10 vertebral body was also affected. So after getting that MRI, it showed all the things which I mentioned, and also multiple areas of pyomyositis with muscle abscesses within the iliopsoas and gluteal muscles as well. So the final diagnosis is disseminated staph aureus. We were presuming this was a primary right femoral osteomyelitis with septic thrombophlebitis and DVTs of the right popliteal and femoral veins, and then the left popliteal vein as well. He had pulmonary septic emboli. Osteomyelitis, in addition to the right femur, the left fibula, the right radius, and the T10 vertebral body were also involved. Had septic arthritis of the right knee. Multiple sites of pyomyositis, emboli to the spleen, kidneys, liver, and skin. And on subsequent echo, there was a very small lesion on the chordae of the mitral valve, which was suspicious for endocarditis. He certainly had an intravascular nidus in the form of the DVTs, but this was a potential other nidus of infection as well. So he did end up having methicillin-sensitive staph aureus. So as Nidhi asked for the PBB2, that's a very rapid monoclonal antibody test. It's a latex agglutination that comes back very fast. So we asked for that immediately from the microlab. And as Nidhi pointed out, this is a child who you really want to maximize therapy and be ultra-aggressive because there are very high rates of morbidity and mortality with disseminated staph disease. So he was immediately started on high-dose nafcillin, 200 mg per kg per day divided Q6. He was treated for a full 6 weeks from negative blood culture. Gentamicin was added for potential synergy despite the renal function. So again, as you point out, you can give a dose, check levels, and monitor it that way. Rifampin was started for a short period of time, and I have the next slide talks about synergy, so I'll go into why we chose Gent over Rifampin. And he did get a couple doses of IVIG. There's data, at least in MRSA, that there's some component of exogenic toxins which play a role in this disease process, so he did get a couple doses of IVIG as well. So we sent his isolate up to UCLA for these synergy studies. This is what's called a checkerboard analysis. So you take serial dilutions of rifampin or whatever drug you're using here, and again serial dilutions here, and you see whether the combination is either synergistic, antagonistic, or indifferent. And he did indeed have synergy with nafcillin and gentamicin. That's why we chose that particular cocktail. So if you were to ask at this time, this was about going on 3 years ago now, 10 ID docs, once you knew that this was staph aureus, is this MRSA or MSSA? all 10 probably would have said that this was MRSA. But in the literature and anecdotally here, we've seen an increase in MSSA causing severe sepsis, disseminated infections, necrotizing pneumonias, etc. So what we sought to do is figure out why that's happening. So this is work that we've been doing up at the Scripps Genomic Institute. This is the whole staph genome. So this is sequencing the whole genome of these bacteria. This is over about 10 years here at Children's Hospital. The red isolates here are invasive MRSA infections. The green ones are MRSA, which cause skin and soft tissue infections, which is certainly the bulk of disease in the pediatric population. And what we were seeking to do is see if there's a genome difference between these two different isolates that would explain why one's more virulent and one doesn't cause a severe disease. And then interestingly enough, these orange isolates here are kids who had disseminated MSSA. As you can see, the genome is essentially the same. The only difference is this black area here, and this is where the MEK-A cassette is. So in essence, these bacteria are the same as MRSA. They seem to have dropped this MEK-A cassette, so the only difference between these isolates is methicillin sensitivity or resistance. And in fact, we did some phylogenetic analysis looking at these different isolates. They all seem to have a common ancestor. So this is the proverbial wolf in sheep's clothing. And in fact, this is his isolate here. So very highly related. I should explain this. The green ones are MSSA. The blue and red ones are MRSA. So this isolate is very highly related to MRSA. So the kind of further clinical course, he was admitted in November of 2008. Again, went to the PICU for respiratory distress and hypotension. Was intubated for about 2 weeks. Proved very difficult to ventilate. And was in the PICU for the better part of 4 weeks. Went to the OR multiple times. On hospital day 3, had the right femur and subperiosteal abscess IND. Went back a week later for bilateral femoral INDs with troughs. Had a bilateral knee open arthrotomy and a left fibular IND. Went back a couple days later to again wash out the femurs, bilateral knee aspiration, the left fibula and ankle IND. And then finally, now 17 days into his course, again, a repeat IND of the right femur and a right knee and ankle aspiration. So this is this young man when he first was admitted to the PICU. Again, proved very difficult to ventilate, was on the rotobed. You can see the number of drips he needed here for pressure support. The number of surgeries and drains here in the bilateral lower extremities. And ultimately, he ended up being discharged from the hospital 45 days later, completed a full 7 weeks of antibiotics in-house of IV, and then we switched him over to high-dose oral Keflex, and he completed a whole year of therapy before we stopped the antibiotics. He did have a DVT, as mentioned. He was treated with Lovenox. Did have the sequelae of some mild hypertension, but over time with aggressive OT and PT, he went from here on the rotobed on multiple drips, intubated, to sitting up in bed, to smiling, and getting some PT here. And 2 years later, this is his femur here. So you can see the right femur still doesn't look normal. You can see all these sclerotic changes. But again, much improved compared to 2 years prior. And one of the reasons why I chose this case, in addition to this presentation being very interesting, that this is something that you don't want to miss because the risk of missing it and not treating it appropriately carries very high rates of morbidity and mortality, is this is a case, this is one of my first cases as a fellow, and it really reminds you of why you went to medical school, why we chose pediatrics in general. And here he is, pretty amazing kid. 2 years later, rode his bike across the state of California, and I have a special guest here. His name is Reilly and he wrote for a school project about his experience of being in the hospital, which is one of the more poignant things I've ever read. And so I'd like you guys to join me in a round of applause for Reilly. And he's nice enough to share with us.
Yeah, I can't read it. I have to read it out of my pocket. The big, loud silence blocked all other sound. My heart was thumping so much I was shaking. I could smell the gasoline from my couch. Then 2 people came in. The 2 people picked me up and I screamed. They put me on a big, uncomfortable bed and wheeled me out the door. They took me to a big, red, loud truck and put me in the back. It changed my life forever. The next thing I knew, I was in the emergency room. Everybody was staring at me with big eyes. I can't remember the faces, but they were staring at me. After one crowd left, another one came. Then a man came along and said something, but I can't remember what. Some people took me to a big, large, round, black and white machine. Then they put me on a big metal table next to it and went behind a glass wall. Next, the table started moving into the machine. Later, I came out of the machine. They took me to a small room with a TV and a bed. There, I started to lose hope. I was also thinking I was going to die. I was in so much pain everywhere. Then a doctor named Chris Canavito told me that I had staph. The doctors gave me a lot of medicine. Slowly, I got better. Then I was out of there, home. I had the biggest grin ever. Everything seemed bigger than I remembered. Then I realized I learned something. I learned to never lose hope and miracles happen.
Pretty amazing young man, and his parents are here as well. Just amazing people. So we'd be happy to answer any questions you guys have about the case.